Hello, this is Debu Tripathi, Editor-in-Chief of Cure Magazine. I'm at San Antonio, and we are now into day 3 of the meeting with several new findings. There was one today that is a question that has vexed oncologists and patients alike for many years, and that is, what do you do if you've had early stage breast cancer and had chemotherapy, you're doing well, and now you have a local recurrence? It's not that uncommon. About 5 to 10% of patients may have a local recurrence at some point, and it may still be curable with more surgery. For example, after a lumpectomy, you can have a recurrence in the breast, or even after a mastectomy in the chest wall or under the arm in the axilla. And after resection, should you get more chemotherapy? That's the big question. And in the past, we've done it sometimes, not done it other times, but we've never had any data from randomized clinical trials. These are hard trials to do because most patients or physicians believe that you either should or shouldn't, and they wouldn't want to be randomized. So nevertheless, it took 3 cooperative groups in the United States and Europe to finally do this trial. They were able to randomize patients, but they weren't able to enroll all the patients they wanted to. They wanted to enroll 500 or 600. They ended up enrolling under that. But they did find that when the trial was done, that there were fewer recurrences in the group that was randomized to chemotherapy. They didn't specify what chemotherapy. They just said anywhere from 4 to 6 cycles, and it had to be at least 2 drugs. So they let physicians choose what they thought was appropriate. And it was particularly helpful in lowering the risk of recurrence in patients who had estrogen receptor negative cancers, not so much with estrogen receptor positive, in which case these patients did get more hormonal therapy, but it was unclear in that group whether chemotherapy benefited. So this does really give us better guidelines now for patients, and the bottom line is when there is a recurrence, if the tumor is ER negative, consider chemotherapy. If it's ER positive, maybe it's a little more of a difficult question, but definitely a different form of hormonal therapy should be used. Another study that was reported by the group in England is a study of radiation therapy given in a shorter period of time. When radiation is given for early stage breast cancer, almost always after a lumpectomy, and sometimes even after a mastectomy, it's given over about 6 weeks, 6.5 weeks. It's terribly inconvenient for a lot of patients. And we've always wondered whether we can give higher doses in a shorter period of time, say over 3.5 weeks. That was tested in a large study done by a group of investigators in the UK, and they reported their results 5 years ago, and now they're presenting the 10-year update. And what it shows very convincingly is that you can do it in 3.5 weeks. The results are just as good, and this is now the standard of care in England. And two of the questioners at the conference said, well, should this be the standard of care in the U.S.? And absolutely it should be. Now, whether or not that will actually happen remains to be seen. But this included patients with positive nodes, negative nodes, and so we'll see if this gets adopted here in this country. But boy, it would certainly be a lot more convenient if we could move to that schedule.